Good afternoon and welcome to Iowa Ideas. This session, as Pam said, is Data in COVID-19. I'm James Lynch. I cover politics and state government for the Gazette. When I wrote my first stories about COVID-19 7 months ago, I didn't think we'd still be talking about it in October, but here we are. Over the past 7 months, Iowa COVID-19 data has undergone several changes in the way it's presented. And today we're here to discuss the value and importance of that data, as well as what happens when these changes and corrections challenge public confidence in the data. And to help us understand that, we're joined today by Dr. Kelly Baker of the College of Public Health at the University of Iowa, Dana Jones, a nurse practitioner at the University of Iowa, and Sara Willette, who runs iowacovid19tracker.org and compiles data for Iowa schools. I want to remind folks in the audience that you can submit questions, and we'll get to as many of those as we can in the hour. Starting with you, Kelly, take a minute to, I guess, just introduce yourself and tell us how you got here as, sort of tracking COVID-19 data and following the data.
Sure. Right. So I am faculty in the Department of Occupational and Environmental Health, and I have a secondary in epidemiology. My area of expertise is infectious disease epidemiology and microbiology, and most with what I tend to work on is hygiene-related transmission, actually on the other side of the world, in Africa and Asia. We typically are studying things like diarrhea and helminth infections, but hand hygiene is very much wrapped up into transmission of respiratory viruses as well as the sort of person-to-person contact. I am supporting some domestic work on COVID. So I'm supporting a project at the University of Iowa Hospitals and Clinics looking at seroepidemiology of COVID among healthcare workers across a range of different sort of occupational levels. And then I also support the National Academies of Medicine on global policy response and capacity for dealing with COVID-19. And then, of course, as a parent, I have an in-depth interest in what's going on in our schools and how our schools are each responding as either as individual institutions or in a collective to the recommended public health measures from scientists as well as from the Department of Public Health.
Thank you. Dana, tell us what brings you here.
Yeah, so a little luck maybe. So I'm a nurse practitioner at the University of Iowa, but I do not actually have a background in epidemiology outside of my general degree for my doctorate, but I actually specialize in bariatric surgery at the university and became involved in following the data as a citizen. So did this separate of my role as a nurse practitioner at the university. I started following the data mostly out of sheer curiosity and concern, worrying about the vast difference of reporting of data from one news source to another, and the IDPH website. The constantly ever-changing display of data was concerning to me, and I felt very much out of control of what was going on around me. And as a nurse, with a background in nursing and healthcare, definitely had a little bit of understanding about how this should go and how those things should look. So I did decide to start following the data a little bit more closely, first in a paper journal and then in a spreadsheet, and it sort of has evolved from there, but hasn't gone as far as Sara has gone in building a website. In following that data, did find some pretty significant discrepancies that were happening, and happened to get an answer, happened to get a response from IDPH. So, and the rest is history, I guess.
Sara, you were nodding your head as Dana was speaking. It sounds like you didn't set out to be a COVID tracker, but sort of came upon it accidentally.
It was definitely accidentally. I just like Dana, I was keeping track in the beginning in my own little spreadsheet that was on my computer. There wasn't any internet presence. I was sharing screenshots of graphs once a day to try to keep the few people, like my family and friends, everyone that I care about here in Iowa and across the country, just kind of updated on what was happening here. And slowly over time, people started telling their friends and telling their family members, hey, follow this girl. She posts graphs every day to explain what's going on and tries to help give some context to what's happening. And again, by happenstance, my tracking of our state's data turned into trying to understand what was happening in our schools. And then I partnered with ISEA, the teachers union, to track all the school positives and all the notifications that were happening on a daily basis, or in this case now it's multiple times a day for multiple districts across the state. And I do my best to try to keep everything as current as possible so that we can understand what's happening in our schools.
Okay, thank you. It seems like there is an awful lot of data out there about COVID, and unless you're into numbers and spreadsheets and graphs, it's easy to feel like you're drowning in data. So to start this discussion, let's talk about what numbers people really need to know and really need to see. And so, Dana, let me ask you first. What are the first numbers you look at every day? I mean, we see positive tests, hospitalizations, ICU numbers, deaths, of course. What do you see, and what do you think is like the one thing that everybody should know? If you know,
well, it would be lovely if we had that number. So
just to be okay.
Yeah. So I think one problem is that we aren't really looking at things in this state on a population-based level. And I think Kelly, in our previous discussions, you've touched on this, and I'll let you speak to this more because you know more than me. But right now, I just download the data that they have available and compare it to itself and try to see what the changes that are occurring are. As far as helping me understand what's going on around me, no one number is going to answer that question. And I really look at all of the data. How much testing are we doing? What is the positivity rate telling me about how much testing we're doing? How many positive cases are happening, not just across the state, but in my immediate community? What does that tell me? Hospitalization rates kind of are a lagging indicator of what community spread is. So while it's important to know, there are so many factors that come into play and things to consider when looking at hospitalizations. One thing to know, for instance, is that the University of Iowa is caring for many COVID patients outside of the hospital setting. So those patients are being cared for in telemedicine, and some of them can actually be using oxygen or monitoring some pretty significant vital signs from home. So, and that's an amazing, wonderful thing that they've done. But it does, that may not be available everywhere. And so our hospitalization data here in our community may not be comparable to other communities across Iowa. So, there are like you said, you can feel like you're drowning in data and information right now, and really we are. And I think that really touches on the importance of having someone to help guide us and help drive this data into a meaningful direction for us, and then put policies in place that can help protect us.
So Kelly, Dana sort of put the burden on you here. What is it you're looking at, and what numbers do you think we need to follow to get an accurate picture, or the most accurate picture?
Well, I mean, certainly, certainly hospitalizations and mortality are very useful indicators, right? They're the canary in the coal mine that things are going bad really fast, and that we may have health system issues, with sort of overcrowding and other problems coming about. However, and of course, the sort of norm these days is to look at positivity rate. Starting off tracking pandemics with a positivity rate is a very natural thing to do, because when we start pandemics, we sort of assume that the people who manifest symptoms are the people who are infected. But what we have learned over the course of the 6 or 7 months now that the pandemic's been in the United States, and a couple months sort of longer timeline for global, is that there are a lot of asymptomatic people out there whose role in transmission is not completely clear yet. We know asymptomatic people can transmit the virus. We just don't really sort of understand at this point, due to poor contact tracing, how important they are. COVID also has a very long sort of pre-symptomatic period relative to the flu, for example. And there is strong evidence that pre-symptomatic people, sort of can not only transmit, but for example, the spread of the virus into Germany was a pre-symptomatic businessman that had traveled to Germany and attended a meeting. And so when we are talking about top positivity rate, the denominator for positivity rate is heavily influenced by things like, well, are testing everybody who has symptoms reliable for understanding how many people are walking around in our community with this virus who might be a risk to others? And ergo, the policy on who we test influences that denominator. So I think that, in addition to positivity data, one of the things that we really need to start incorporating at the state level is more data that, as Dana alluded to, is population standardized. So you can look at the CDC's website as an example of this. We need to have, the number of cases that have been test confirmed, the number of hospitalized, the number of deaths, standardized to 1,000 or per 100,000 in the population so that we can track trends going forward. One of the other advantages of doing this is that flu and the SARS-CoV-2 virus that causes COVID-19 exhibit very similar symptoms, and we are just now getting into the flu season. What this flu season is going to look like is a bit of a wild card. We can perhaps take a little bit of hope from seeing astronomically low flu rates in the South, where they've just ended their flu season. So South Africa and Chile and Australia have had a 0.06% case rate for flu compared to what is normally a 14%. That being said, these are also populations that are much more compliant and as a whole in following public health measures. And so while I really hope that we see the same sort of flat line for flu rates, it's possible that in pockets of the United States, especially where public health practices are non-ideal, that we are going to start to see co-pandemic and flu epidemics happening at the same time. And that means that denominator, the people who are going to be going to get tested because they're exhibiting symptoms, that's also going to start fluctuating because of this other disease. And that means that as we go into the flu season, we're going to spend some time sorting out how do we compare positivity rate in the flu season to positivity rate in June or July. So I would like to see some more of the actual count per population data extrapolated backwards as well, so that we can really look at those trends without some of these biasing factors.
And Sara, thoughts on this?
Trends are exactly what I look at as well. I think it's important for us to understand what's happening currently, but the only way we understand that is by looking at what has happened and what our trajectory is going to be looking like, provided behavior is maintaining. People are going to the same stores and they're sending their kids to school and doing all the things we normally do. If we look at how people are behaving now and what that is showing up as in active infections as well as in recoveries, we'll have a reasonably good idea of where we are at currently. One of the things that I like to look at is percent of any county that is infected at any given time. And I can look at that that percent infected and see how that's changing. So we can see if, for instance, Adair County is currently increasing versus, say, Johnson County that is mostly flat, although they're starting to see increase there.
Okay, all right. Let's talk about the data that we're seeing. And my understanding is that pretty much everybody is taking the data that the State Department of Public Health is presenting and working off of that. Do we have the right data? And from some of the comments you've made, I am guessing that we don't necessarily have the right data. And so what's missing, and is there other data that the state should be collecting that would be beneficial to just regular folks, as well as people who are making policy decisions? I don't know who wants to go first here. Dana, thoughts on that? Are we getting the right data, and how would you rate the quality of it?
Yeah, so, from my perspective, the way that I look at the data is different from how Sara looks at the data, and the things that I'm analyzing are different. So one thing that has bothered me that I still don't have a really great understanding of why they're doing it the way they're doing it and why they haven't changed it yet. They are not maintaining the prior data. So they still today, as of this morning, are not keeping past testing data. So they have some of it, but it's incomplete, which makes all of it completely inaccurate. You can't use it for anything. So for example, they are still using total individuals tested. So that means that they're only going to keep one test result for each individual person. And I know of one person, the governor herself, who has tested multiple times. So what happens to the testing data when a patient or a person is tested multiple times? They only keep the most recent result. So that means that many thousands of tests are being removed from public view from prior dates. One other thing that I've noticed as I'm comparing the data to itself each day is that we're losing positive cases, which is really curious to me. We're losing positive cases from dates all the way back in March. And I kind of wonder why. Does this mean that people who were tested positive for COVID in March are testing positive again in the last 2 weeks? What does that mean? So, I think it's really important that they clean this up, and they need to be keeping all of the data in public view. So
Sara,
that's one thing.
Sara, you're nodding your head again. You want to see more of that data, previous data?
Yes. What we need is multiple test cases per individual person. I know quite a few people who've been tested multiple times because of multiple exposures. And if the only test that's being kept is their most recent test, for that individual person, we can't look at what it's looked like for them over time. And if we then extrapolate that out to a little over 3 million Iowans, we can't understand how the pandemic is affecting all of our lives as we move through. If we had all of that test case data, both positives and negatives, we would be able to understand what's happening in our individual communities a lot better, at least.
So Kelly, I want to ask you, does the lack of a complete data set, I guess what we might call it, as well as the frequent changes in how the Department of Public Health has been presenting its data sort of open the door for the pandemic rejection folks who sort of question all the data and question the severity of COVID-19? And what does this do to public confidence in that data that they're seeing?
Right. Well, it has certainly stirred up a lot of concern about and fear of, the non-transparency has certainly stirred up some concern among people, and it's actually spurred lots of micro Sara Willettes and Dana Joneses who are now out there pulling information off of school websites and saving it because, the policy now is that the schools only show back 14 days, right? They're only presenting that data, not showing cumulative. So the sort of history of what's happening and our ability to link changes in school policies or county mandates, is sort of disappearing. And so, yes, there's absolutely, I think, a benefit for being much more divulgent with all of this information. So, I second what Sara and Dana have said at this point.
I want to ask, is this a bit like the weather in that when I get up in the morning, I want to know what the forecast is for today? But if I was a meteorologist, I would want to see the data, have all the data from, what have the weather trends been, what has happened, and as I think it was Sara said, based on those trends, what should we be looking for? So, the data that's being presented, is it good enough for, me to get up and say, okay, the numbers are going in the right direction or the numbers are going in the wrong direction. But then there's another set of people who need much more complete data. And I guess the question is, are they meeting either one of those standards?
I would say no, because I mean, going back to some of the flaws with using positivity rate, we have had some changes in policies about testing over time that have made it sort of difficult to connect what does a positivity rate today mean compared to, previously, months ago. So no, I think it has become very difficult to track trends over time. And as I alluded to with the flu, it's going to become a little bit more difficult to track trends going forward if flu shows up on our shores as usual.
So we have a question from somebody in the audience who was asking about sort of the skepticism that the public is showing towards this data that's being publicly available. And I'm wondering, if there isn't confidence in the data, Sara, what's kind of the short-term or immediate impact of that? I mean, how does that affect us right now?
So when we can't trust the data that we're being given regarding positives and negatives and what trends are looking like, it makes it very difficult. And especially the way the state presents the data, it's very difficult for people to understand what had happened yesterday versus today, because the state's website just wipes and repeats the newest information and it keeps updating, but it doesn't show historical trends. So we can't even look at the last 7 days very well, since the state's own graphs that are longitudinal, those have also changed repeatedly with backdating of tests or removal of tests. These graphs keep changing on us. If we had all of the data that was originally in those graphs and all of those test cases that existed, we could see what testing had looked like last month, the prior month, every month before, all the way back to March. Same thing with positives as well as recoveries. I have a very difficult time, and I hear this from many Iowans every day. I look at the state's website and it's very static. You don't get to see how many kids were positive yesterday versus today, unless you keep track of those numbers yourself, which requires every single Iowan to devote the time. A lot of us don't have the time. We have families, we have jobs, we have responsibilities. We can't sit down for 2 to 3 hours and aggregate all that data. And that's a big problem, because it should not be on individual Iowans to aggregate that data and present it in a way we can look at. That's the responsibility of our state public health department.
Dana, same question. What's the immediate impact of data that's either incomplete or that you can't have confidence in because of some of the things that Sara was saying about how you don't have the historical data even from a week or 2 weeks ago?
Yeah. Well, from the perspective of a citizen, it's anxiety provoking, right? So I'm trying to make decisions for my family, some of whom are a vulnerable population. My parents, I rely on them for childcare. My mother-in-law, I want to keep these people that I love safe. And I feel that the onus is on me, that I don't have all of the tools that I need to do it. So there's that piece, but then also, thinking about it from a public health standpoint and from a professional standpoint, thinking about, Kelly Baker, and thinking about Eli Princevich, and thinking about, all of these great people who are that I know are dedicated to trying to keep us safe, not just during this pandemic and in the here and now, but in the future, and trying to gain understanding of this pandemic so that it can help drive decisions in the future or help drive care in the future. They're going to want to look at that historical data so that they can study these trends and, which policies did we put into place that had, what effect on this population and on these infections. And if we don't have a complete data set for all of the time frame of this pandemic, we can't do any of that very important research, not just to keep us safe today, but to keep us safe for decades and centuries. Like the importance of research. I am baffled. I really am. I cannot wrap my mind around it.
Kelly, I want to come to you because looking at that in terms of, future pandemics and the research angle on it, you told me that data is historical as well as contemporary. Explain what you mean by that and the importance of that.
Right, right. So what I was alluding to is that we as a population have the benefit of living in a bubble at this point, right? We have sufficiently knocked infectious diseases off of our sort of major burden, major causes of death, with the exception of flu, right? Flu has remained the 5th leading cause of death in the United States. But for the most part, we don't have a lot of historical memory of what it feels like to live with communicable diseases running rampant through our population, either constantly or perhaps seasonally. But it wasn't that long ago that they did, right? I mean, 100 years ago, typhoid fever in a lot of our cities was very similar in terms of number of people per 100,000 in the population as low-income countries today. During people have heard a lot now about the 1918 pandemic. A lot of the public health measures that were implemented there are identical to what we're saying today. People wore masks. They did shut down institutions temporarily. The sort of first reaction was shut down and then thinking about how to reopen. Hand washing. Even in the 1950s, so my mom is in her mid-70s. And in the 1950s, we were still working on getting rid of polio in the United States. And she has memories of polio outbreaks going through Arkansas, where schools were shut down. She had to sit at home with her mom overseeing, her learning. People were, had a heightened sense of awareness about hand hygiene. So these sort of experiences are in our nation's history, and we have learned from them, which is why we have arrived at the public health response that has been practiced in this pandemic, at least, from the sort of NIH and CDC. And so I think it's just an issue of us needing to relearn the consequences of ignoring those messages again.
And I want to come back to Dana and Sara. I can't remember which one of you told me that you've heard more than once the state seems unwilling to accept the help of sort of the, citizen researchers, the citizen trackers out there. The governor referred once to people who have their own spreadsheets. Sara, what is the state missing out on by ignoring this Google Docs army?
All of us want to help the state. We want to help our counties, our cities. We want to do whatever we can to help clarify, describe, break things down in ways that all of us can understand, because not every single person is an infectious disease expert. They're experts for a reason because they have content expertise. But we want to know how to go to the grocery store or send our kid to a school, or whether or not we should go to the park. But that's going to require more people understanding and explaining and working together than just our public health departments, who are very obviously overburdened. I know of a number of county health departments who they don't get the funding they need. They don't have the employees they need in order to maintain and sustain and do the contact tracing. And without all of us independent tracers, trackers, researchers, everything that we do, our state is missing out on a large group of people who want to work and we want to help. It's one of the big downsides to ignoring us or belittling us on, public television.
Dana, you don't have to do the tracking that you're doing, but you're tracking this in a way that, coming from your healthcare and nursing perspective, you feel is valuable and worthwhile. So why isn't that thrown into the mix? Why isn't that welcomed by the Department of Public Health?
Yeah, I don't have a great answer for that, honestly. I feel like in some small way, I feel like it has made a difference. They have listened, right? When I look at these things and I see these changes and I send a message, and then a week later they're having a press conference and making a change to the IDPH website view, or making a change to the way they're doing things, I'd like to believe that maybe they are listening. Maybe they are hearing what the citizens are saying, or maybe maybe they are willing to hear that. And that's my hope, right? That maybe that's my naive hopefulness that we all are going to work together and that we are going to rebuild public trust and that we are going to do these things and that Iowans will do the right thing and not just us as citizens, but them as public officials as well. So, you know, I do hope that that can be the case. Sorry, I am hearing dinging and I don't know how to turn it off on my end.
We've all been there.
So, yeah. So, you know, I think that we can get there, and I hope that they are open to that. You know, do they need to have every citizen in the mix? Maybe not, but being open to hearing those things, I think, is important. But most importantly, I would like to see them accepting the help from our public health experts that we have here in the state, because they have an immense wealth of knowledge and expertise at their fingertips. And I would like to see them being open to using that. I know that they're overwhelmed. I know that they have an antiquated system, as they've told us before. So be open and receptive to help, because I know that there are beautiful dashboards being built. Sara has built a beautiful dashboard. You know, there's a lovely dashboard from Grinnell College. There is so much out there and so many people who are just really eager to be there and help because they care about our communities and they of help.
Kelly, over at the College of Public Health, you have a lot of experts, as Dana was just saying. Do they feel like they're being utilized in a way that they could be helping the Department of Public Health and helping, you know, the statewide community understand this and take proper action?
So any comments I could make on this would really be somewhat hearsay, right?
Okay.
No, but nobody has complained directly to me that they feel unheard. I do know that there are quite a few people at the College of Public Health that are very adept at infectious disease modeling, and that some fairly sophisticated predictive models, right? Those that kind of help us figure out where we need to put our resources and our people, you know, in a month from now. I know that there has been quite a bit of output there, and I have not seen it discussed or presented within sort of the public sphere. So, but I don't know the back end story behind that. But one thing so I want to just quickly comment on what Dana was saying. Yeah, I think, you know, I hear all the time from some of the parents that I advise through the school system about how helpful Johnson County public health nurses are and how involved they are and how much time they're spending with schools trying to figure out what's going on. And at the same time, you know, I think the approach has been very hands off, right? So if you go from, I'm going to just focus on schools here because that's what I know best for Iowa. You know, if you go from school to school, the way that they're tracking data, the quality of their data tracking, the quality of the contact tracing, and what their dashboard looks like is all over the place. And it depends a lot on the resources of that school and the extent with which the sort of administration feels that it's important. And what that has resulted in is a bit of a not only a decentralized mechanism for people obtaining data, right? They have to get school data from their school website and hope that it's decent, but then go to the county website to try to figure out what's going on in the community where these schools are situated. It'd be nice to have these centralized. And I know that what we're talking about is a lot of work on people that are really busy already on the practice end of this, right? Providing advice and guidance. So it'd be nice to see more streamlining and centralization of this data, which I think helps us as a community trust that the data is being collected, managed, and analyzed and presented in a systematic fashion, right? We're not guessing as to why one school looks different than another, but it also takes a little bit of the workload off of people who are supposed to be educating, not contact tracing, and off of the nurses who are really supposed to be helping people problem solve on the instant and not trying to track data. So I think a more organized approach where everybody's following the same policies, mask mandate, there is no mask mandate, right? It's still all over the place in terms of how schools interpret the sort of public health, the suggestion that we should be wearing masks in schools. And there have been some schools where it's been a huge fight because the administration has been resistant. So, I think that better organization, better linkage, better usage of people who can predict what might happen in a month, better people who are more, who are really adept at data, large big data management, right, could really help the county. And I also just want to sort of add one other thought onto this, which is that, you had asked at the beginning of this about the missing data, some of the other things that I would really like to see. We don't really have any clue as to how effective contact tracing is working. Sorry, I'm having a sort of tense moment here. There's a fly trying to land on my feet. How well contract tracing is working and whether it is effectively identifying and containing sort of outbreaks is also, I think, a missing piece of this puzzle.
Okay. Sara, I want to ask you about schools, and since you and Kelly both do some work with the schools, what do we know about COVID in schools? How well are they doing, or do we know how well they're doing?
It's definitely school to school. Some schools are doing very well with social distancing, masking, making sure that kids are staying far enough apart. Other schools, not so much. And it's very patchwork, as Kelly had alluded to. When it comes to the data specifically, it's a wide spectrum. There are some schools that share no data. There are some schools that share paragraphs of data. There are other schools that have a very simple dashboard. And then there are schools like West Des Moines that have a very elaborate dashboard. And the issue is when we're talking about standardizing the data, understanding what each school looks like, we need to have a very set type of dashboard so we can look at trends from one school to the next and compare them effectively against each other. We also need to know things like, are masks 100% of the time? Are they only when you're in a classroom? Are they only when you're in a hallway? Are they only when you're not eating? These kinds of things, we need to understand what the spectrum looks like and how each individual school with school district falls on that spectrum. And when we're talking about 326 school districts, that's a lot of data in itself. We're talking about over 1,300 school buildings. Is each school building having the exact same types of masking requirements? Or again, is there a spectrum? And that in itself is a big problem. We don't have all that information for each school district. Some districts originally had no masks. Some districts now have masks. Others are thinking about them in the future. In order for us to understand how the pandemic is affecting kids and teachers in school districts, we need to see when masks were instituted, how they're used, so we can take a look at the change, either decrease or increase in positives with reference to those rules.
So when you look at this, all the data in total, and we've talked about some of the shortcomings of this data, how is that affecting policy decisions and practices that either are being put in place or maybe should be put in place? And I guess this kind of goes back to the question earlier about what are the short-term, the immediate impacts here. Do we have the data we need to make good decisions? Who wants to jump in?
Some of the data we need to make good decisions. We don't have everything we need. One of the big pieces that we're missing is how recovery is looking for people who are deemed recovered. The state is determining that people are recovered at 28 days and they are no longer tracked by the system. But we know with long COVID, post-COVID illness, recovery does not necessarily mean you get to go back to your normal life and everything is perfectly fine like it was before. There can be lung damage, organ damage, intermittent fevers for no reason, lots of different symptoms that show up in the long term. And what we don't know, especially with regard to schools, what does that look like for kids? What does that look like for younger children under 10, kids under 5, kids that are in their early teens and in their late teens? Because as we grow up and as we develop through puberty, infections look different for each individual person. We need to understand by very specific age groups what recovery looks like in our schools so that our schools can then help support families that are dealing with long-term recovery issues.
Kelly, in your work with the schools, do they have the information they need to put policies in place?
I would say not so much. I mean, do a lot of the things that we had talked about today, right? I mean, just the 14-day cutoff, sort of curtailing our understanding of how often cases are popping up again across elementary, middle school, high schools, right? I mean, there are some age groups that are lower risk for COVID or COVID symptoms, right? Like at the elementary school age, and others that are higher risk. And so tracking some of that information. Also understanding, I mean, it's been really unclear how going back to contact tracing, how contact tracing has occurred in our school system, how are schools dealing with, sort of following outside of school events like athletic events. Are these being recorded in the case numbers? Are the quarantine guidelines recommended by the county public health office being applied the same way? There is definitely this is not being communicated extremely effectively, at least in some of the school districts that I am familiar with. And I think, again, it's, I think it's a little bit because of a top-down requirement for how some of this needs to be conducted identically across school systems.
We have a question here from an audience member who's asking, I think maybe Dana, you were the one who mentioned this, that talking about losing positive results from March. And they're asking, does that mean an individual tested negative and their previous positive results were thrown out? Or just, can you explain that?
So my understanding, So my understanding of how that is happening is a little shaky, but I think from the explanation I got from IDPH, they said that repeat negative tests, I think, throw out prior negative tests, right? Is that right? Do you remember, Sarah?
Yeah, I believe that's how it works.
Yeah, and then the positives only if they're outside of 90 days, right? So if you're tested positive in March and then tested positive again later, 90 days out, then that initial positive wouldn't be kept. I believe that's, if I'm understanding it right. And then all negative tests. So if, let's say I've been tested in March, April, May, and June, and all of those were negative, only the June result will be kept. So you'll lose those tests on all those other prior dates. So the result of this is that we're losing thousands of individuals tested from dates prior. And then also, as I'm looking at my spreadsheet here in front of me, we lost a positive on March 18th. We lost a positive on April 20th and the 23rd, and 2 on the 25th and the 26th and the 27th. And so, it's happening. There's something going on, but do I know what it is? I don't, because I don't have that data and I don't have that information. But it does definitely, it's concerning, especially if that means that that's 2 positive tests now that someone has had outside of a 30-day window. I'd like to know if that's happening in Iowa, especially considering the most recent reports of someone having been reinfected with a different strain of COVID.
Thought just popped into my head talking about the testing, that these are tests conducted by like Test Iowa, public health departments. I don't know hospitals and doctors' offices. But I went to an event where they required everyone to be tested before they went in. I'm guessing those results were never put into the system. I mean, this was sort of, it was not a public event, you know, hosted by a public agency or anything like that. I'm guessing those test results, and I know there were some people who were turned away, probably never went into the system and aren't reflected in the numbers that we're seeing from the Department of Public Health. Do you think there's much of that happening? Or maybe in workplaces where
I would hope that wouldn't be true.
Are, you know, doing even the temperature checks?
Sure. So,
Okay.
you know, I would hope that would
I mean,
be true.
it just occurred to me as.
Yeah. You know, the question really for me would be, were those point of care tests? So are those tests that were a card that they were able to read it right there on site? It didn't have to go through a lab. Because my understanding is that anything that goes through a lab is being transmitted to IDPH into IDSS directly with HL7 message. So it's my understanding all of that data should be happening, but point of care testing is tricky, right? So this requires a manual entry of those results to be put into a system and then sent off manually, either like by fax or by what, I don't know, electronically. I have a feeling that there are many different ways that information could be transmitted. Now, is it possible that maybe people are doing point of care testing in various scenarios like you just described and then not transmitting that data? That's possible. Is it a great idea? No, it's not. But I know, wasn't there recently a whole boatload of negative tests that were point of care tests that weren't transmitted and then they were dumped?
Yep. Yeah, and they were added in later.
Yeah, so we have a little precedence for that. So it could happen.
Okay. We have another question here from somebody who is asking in your in your tracking, have you seen any action that could have been taken or done differently that was not and this is in regards to thresholds or hotspot identification?
Oh, James, you're frozen in time.
Or another situation that could have been acted upon. Oh, sorry, am I back? This person is asking about whether or not you've seen action that should have or could have been taken based on data where no action has been taken.
So when we first started seeing Northwest Iowa increasing, and we also were receiving anecdotal reports of people going to, say, Okoboji and not wearing masks and boating like thousands of boats and thousands of people. That was a point at which individuals needed to pull themselves back, wear masks, stay home to try to slow spread. Because of course, as Kelly mentioned, we're dealing with asymptomatic and pre-symptomatic spread, and we don't know exactly how much of that spread is asymptomatic. But a good percentage of it is going to be pre-symptomatic because those people will eventually develop, symptomatic COVID-19. And before we get to those, like the symptoms showing up, people needed to pull back, but they weren't. They were continuing to go places and do things and not wear masks. And now Northwest Iowa is essentially on viral fire, and now they're pulling back, but the train kind of already left the station. And yes, it will slow down, and positivity rates are starting to decrease in Northwest Iowa, but it could have been prevented provided they had worn masks, socially distanced, stay home as much as possible ahead of the problem, not after the problem showed up.
Also, a person is asking what states are doing better or doing well with data tracking in their consistency and transparency, and what are the key elements of their success in your opinion? Who wants to field that?
I guess I'll start.
Okay.
You want to start?
Go ahead.
I would say New York is doing a wonderful job. Wisconsin has a de-identified data set that is downloadable both in full and in portions based on what you want to go ahead and analyze. California has a good data set. Minnesota is very transparent. Whenever they get a new testing type, they add it as a note, and they have exponential graphs for testing as well as for positives. And they show standardized references to cases, not just a straight number. They provide information that helps their residents know if it's safe or not to send their kids to school or to stay home.
Mhm. Speaking of different types of testing, person asks, some pharmacies have people do a self-swab. Do you have any concerns that they may not be doing that testing correctly and that those results are not accurate? Dana, any thoughts on that?
Yeah, I think that, there's always going to be variability in test administration, even when a professional is doing it. And when you have, someone who is not a medical professional administering the test, certainly there is going to be some level of error. It's a really uncomfortable test, the nasopharyngeal swab, and I don't know that I would be able to do it to myself. I had one done, and I just don't know if I would hold it up there and twist it for as long as they did. So I certainly think that there is some room for error there.
Okay. Yes, I've done that, and the event I was at, pretty much everybody had that question. Was, am I doing this right? Did I push it up there far enough? Did I leave it in there long enough? And none of us knew. So we're still here. So I guess we didn't have COVID. I
wouldn't pick it. I definitely wouldn't say don't test instead.
Right. Okay. Do the test. Yeah. All right. We're coming up sort of on the end of our hour here. I wanted to ask each of you, especially Dana and Sara, how long are you going to keep doing this? I mean, I don't know if you thought you'd be doing this after, I don't know, 6-7 months. This is time. I don't know if there's any expense involved other than basically your time, but can you outlast this pandemic, Dana?
Well, the good news is I'm not as detailed as Sara, so I can focus on my other life. But at this point, I don't download the data daily anymore. There's not a lot of futility in doing that for me. I'm gonna be able to tell the same thing by doing it weekly for the purposes of what I'm doing. So I download it, and now I have like my little warrior team. So I know that if I didn't download the data one day, I can be like, hey, Sara, did you download the data? Or hey, Young, did you download the data today? So I know that I have these resources that I can go to also. So we're stronger in numbers, and I feel like I've been very fortunate to find a really amazing group of people who are like-minded and also concerned about what's going on with the pandemic here in Iowa and in the country, and are watching it. And so I feel like we're in it for the long haul. I don't know about you, Sara, but I'm definitely not going to give up until I feel like I have good data to go to, and I feel like I have a safe environment here in Iowa. So
I'm of the exact same mind. My plan is to do this until the pandemic is over and the last few cases have become extinguished and the world is safe again for both immunodeficient people like myself, but immunologically healthy people like Dana and Kelly. Because really, in the end, all of us are me right now. Nobody has immunity, and we don't know how immunity works yet. So I want to have that data, both historical as well as longitudinal, so that we all can know what's going on, be as safe as we can, and also for my own sanity. That's very important during the pandemic.
Mm-hmm. And Kelly, like Sara, you do work with schools, and I suppose as long as the need is there, you're going to keep doing that, as long as the schools need the data and need your input, you'll continue that?
I guess to be a bit so clearer on that, I'm actually supporting parents who are trying to make sense of what's going on in their schools, right? The schools, rightfully so, are looking to county public health officers. But this sort of group of parents that I work with are very proactive at, to a lesser degree, doing what Dana and Sara are doing and really pushing for more information, more communication, changes in the way things are being done. And the sort of actions that have most empowered them to be citizen scientists have been sort of when the county has taken action that has compelled the schools to institute mandates, for example, for masks. Some of the things that have been done in the school wouldn't have happened otherwise.
Okay, so there'll continue to be a need as long as COVID is around.
Well, there's certainly going to be a need for citizen data trackers, and I think that there is probably going to be an ongoing need for citizen advocates, who are sort of constantly pushing for better transparency, better communication. I guess I would like to make the point that there some of the with our mask mandate as a state, right? Some of the arguments that have been put forth for not mandating mask wearing in the state of Iowa has been about enforceability and variability across counties, et cetera. But when we talk about institutions where people have to come together, in some cases by law, right? Our children have to go to school or get an education one way or the other. And for many people, there is no choice but to send their children to school. When we're talking about people that are compelled to come into these public institutions, this is a point, I think, where the lines are no longer gray. We shouldn't be counting on people to do the right thing, because by not having really strict and clear guidelines that protect people from each other, it's being left up to the interpretation and the political will that is within that system. And so there are schools around Iowa where children are at risk from people around them who are ambivalent, yet, for one reason or another, they cannot opt out of that system. They don't have parents that can stay home and educate the child instead. So I think, we could improve policy by drawing a line at where are masks mandated and where are they not, and particularly focusing on these vulnerable populations. Nursing homes is another one.
All right.
You froze again.
Well, we're going to leave it there. I wanted to thank everyone for joining us this afternoon, our panelists, Sara, Dana, and Kelly, as well as our virtual audience. I want to remind you there'll be another session at 3:15 p.m. and you can find the full schedule at gazette.com/Iowa Ideas. And there are sessions Friday. You can find the full schedule there too. Again, thank you all for joining us today, and enjoy Iowa Ideas.